Okay, are you guys ready? Okay. So I'm going to talk about psychological assessment in pain medicine. I'll also try to make some points relevant for palliative care. Some of them kind of go across the board, but obviously sometimes there's differences when we're dealing with people who have terminal illnesses. So I'll try to make it as relevant as possible for palliative care as well. How do I shift the slide? Oh, back here. Can I bring it up here?
The remote.
Is there?
The other guy brings.
Oh, really? I didn't know. They didn't give me one.
All right, I think I could actually.
Yeah, the keyboard too.
Oh, I can?
Yeah, right, left mouse button.
Great. Okay. So just some basic pain facts. That pain is the most prevalent reason why people seek out medical treatment. Chronic pain, as you guys probably know, is one of the most costly conditions, chronic nature of it, and just the fact that people are constantly seeking help for it. These are some old facts, but some of the reasons that we think the prevalence and the costs are so high is also the subjective nature of pain, and the fact that there's so many different facets involved in pain. The biopsychosocial kind of model of pain, where there's psychological factors, biological factors, social factors that all contribute to the presentation and the maintenance of pain. This is tough to see, so I actually brought it along with me because I thought there was one part that I actually might read because I think it really is relevant and probably will resonate with the people who have been seeing pain, chronic pain patients. But basically what this speaks to is this vortex that happens with chronic pain where people have an injury or have acute pain, and how it can kind of develop into chronic intractable pain. All the different factors and risk factors that make people more likely to develop intractable pain. And a lot of those factors are present even before the onset of pain. So some of them are factors that might contribute to the likelihood that they would actually sustain an injury. So risk factors like risky behaviors, drug use, aggressive behaviors, high stress levels, those all make it more likely that somebody will actually sustain an injury in the first place. And then some psychological vulnerabilities once they've already had the injury are premorbid psychopathology, so premorbid depression, premorbid anxiety, premorbid trauma that they've gone through. Also some social factors that might make it more likely that their pain will become intractable are things within the home that reinforce their pain behaviors. People who receive lots of positive attention when they have pain as opposed to when they're carrying out productive daily activities. Other factors like financial distress that might make it harder for them to receive the help that they need to treat their pain. So all of these make it more likely and make patients more vulnerable to developing these intractable pain conditions. So, Kayvon, since you're right next to me, if you could just read this, I think that this is one of the key points of this, and I could also give this to you guys afterwards. Just as a second point, I find that when, for some patients who really have insight into the psychosocial nature of their pain, just describing it as a vortex sometimes resonates really closely with them because they feel like they've been in this whirlwind or this storm where everything's been impacted. They have the pain, they might have these vulnerabilities prior to sustaining the pain, and then all of a sudden things start becoming impacted. They might lose their job, or their job might get much more difficult. Tasks at home might get much more difficult, so their role as a parent or their role as a spouse might begin to change. Then there's a lot of stress in the home, which makes it more likely that their pain is going to be more bothersome to them. So they feel like they're in this kind of downward spiral. So if somebody wants to just read that paragraph out loud, I think it kind of gives a nice description of it.
I read it.
Objective medical disorders are more likely to become intractable when psychological issues are not addressed. Such issues can undermine compliance, frustrate the patient's attempts to make needed lifestyle changes, add stress-related complications, and magnify the patient's perception and report of physical symptoms. In cases of intractable psychomedical disorders involve a somatoform solution. In such cases, the personality is recognized around physical symptoms, which become central to identity, and which supply a physical pathway for expression of effective distress. For example, what's that? Alexithymic? Patients focus. What is it?
Alexithymic, it's in terms of difficulty recognizing emotion. Patients have difficulty recognizing emotion.
Patients focuses on physical aspects of emotion, pain, avoids focusing emotions internally. Additionally, the physical symptoms may provide a face-saving means of seeking attention and support of others without having to expose emotional vulnerabilities. In doing so, the physical symptoms may allow the patient to escape from intolerable aspects of life and justify adopting a dependent role, while absolving the patient from guilt due to any avoidance of responsibility. The report of such symptoms can sometimes also provide financial gain and means of pushing others or rationalizing the abuse of prescription or illicit drugs. Somatoform disorders may move past that into other areas of producing an evolving pattern of diffuse symptoms, whatever the extent of the underlying organic pathology.
Okay, I'll stop you right there, just because it might sound like a big mishmash, but basically what it's saying is that we might see patients at different points at where they are in this vortex. So we might be able to recognize immediately some of these vulnerabilities and address them right away. However, sometimes we catch people when they're kind of already spun downward into the really heart of this negative cycle, and they might have their entire identities really wrapped up in the pain because so much of their former identity before they had the pain is lost. So their role within their family might have changed so significantly that they don't feel closely identified with who they were within their family anymore, or they may have lost their job, or all of those things. So now pain has become the central aspect of their identity, and I think all of us have seen patients like that, and what becomes the challenge with those patients is how to help them reformulate an identity not focused on pain so that they can cope with their pain in a more effective way. Any questions on that?
Can that be done with like the way insurance works right now?
In terms of,
is that really feasible?
I think it is. I think it requires a multidimensional approach. So I think it's not always feasible, unfortunately, but I think if those patients could get into therapy, I think that requires not just pain management from a physician standpoint, but also a lot of emotional support as they're going through that process of kind of reformulating their identity. So ideally, yes, but in some cases, no, in terms of medical coverage, if they're not able to, if part of their vulnerability was financial vulnerability or they don't have medical insurance, then it does pose a huge challenge.
For Medicare, for example, is the coverage sufficient to engage in that kind of therapy that they need?
Yeah, for Medicare, yes. Yeah, so that would be. The other reason that I think it's important for you guys to know this information is if it's not feasible for them to be in a psychological treatment, I think it's important to acknowledge this as their physician if they're not going to see any other specialists, to have a discussion around this sometimes is the starting point. Because sometimes just acknowledging this vortex and acknowledging what the patient has been through, that might set off some things in motion to help the patient kind of reorganize their life. So in terms of the purpose of the psychological evaluation, we want to determine the degree of how they've adapted to their chronic pain. We want to evaluate premorbid psychological state, personality factors, possible psychopathology. This is one of those things, we put it out as a statement, but it's very, very difficult to do. I think you probably have all heard the expression, which came first, the chicken or the egg. In chronic pain patients, it's very difficult to parse out if the psychopathology was premorbid, was present before the chronic pain developed, if it was comorbid, if it was kind of developed at the same time, or if it is a result of how the pain has impacted their life. Very, very difficult to do. It requires getting a really extensive history, and sometimes even with that, it's not so clear. So, and even if patients have been in prior psychological treatments, there are many therapists, many psychologists who don't make giving the patient their diagnosis a big part of treatment. It's not like the medical model where you say you have bronchitis and we're treating it with this. In therapy, it's not always the case that you'll say, well, we're diagnosing you with depression and we're going ahead with this. Sometimes it is the case, but sometimes not. So if you say to a patient, have you ever been diagnosed with a depression in the past, they may have been depressed in the past, but never diagnosed or never knew that they were diagnosed with that in the past. So it's not so clear how to determine this. A big part of the psychological evaluation is not just to obtain information, but also to provide some information, whether you're actually doing psychoeducation during the evaluation, or bless you, or whether you're just kind of conveying it inadvertently, but you want to get across that there's this mind-body connection and the multidimensional nature of pain, so they know that from the start. Formulating a DSM-4 diagnosis, I don't know how familiar you guys are with the DSM, but for psychology and psychiatry, we use a 5-axis diagnosis. Is this all, do you guys all know this? So axis 1 is major clinical conditions or things that wouldn't be specified somewhere else. So grieving wouldn't maybe go on axis 1. Axis 2 is personality pathology. Axis 3 is the medical conditions. Axis 4 is environmental problems and psychosocial problems. And 5 is a global assessment of functioning. It's a number that we assign based on how well they're functioning. So we use that system. To devise a multidisciplinary treatment plan is part of why we're doing the evaluation. To predict outcome of some medical interventions. So part of my role within the department is that I do evaluations prior to people having spinal cord stimulators or intrathecal pump placement. And so part of the evaluation is to determine if it's appropriate for them to actually receive that procedure and to go through that procedure, and to also kind of get a sense of how helpful it will be. To identify any environmental reinforcers of pain. So is this a situation, like I said before, where the patient goes home and the only way they're going to receive attention from their spouse is if they complain of having a horrible headache? And to evaluate the likelihood of chronic pain-related disabilities. So we have a lot of patients here within this clinic and in the chronic pain world who are on disability. If they come to us prior to going on disability, obviously we'd like to prevent that from happening, but also if we have enough information, we might be able to predict if it will happen. So there's some standardized pain measures. Do you guys use that in the clinic here? Do you use any of the standardized pain assessment measures like the McGill pain questionnaire?
Use the VAS.
You use the VAS. Okay, so you just use the visual analog scales?
Yeah.
Okay, so here are some of the pain assessment questionnaires. These are generally used in medical settings. The McGill we like because it evaluates different components of pain, so the sensory and affective dimensions of pain, it targets that. It also distinguishes patients that have underlying psychopathology. The battery for health improvement is actually what that previous slide, the vortex, was based on. So that is something that really targets vulnerabilities in patients and psychosocial stressors. So that's a really good model. If you're going to use that vortex, that's a really good assessment tool to target some of that information. Verbal rating scale, I think, and numerical rating scales, those are the most frequently used. So verbal would be rate your pain, mild, medium, severe, or mild, moderate, severe. Numerical rating scales, that's the one that everybody uses, 0 to 10, 0 being no pain at all, 10 being the worst pain imaginable. And the visual analog scales, a lot of people say that they're using that, but it's really different. The visual analog scale is actually where you have a bar, and you ask them to either tick off like on a range from this point to this point where their pain would be. So is that, you guys use that?
Well,
where they actually...
Yeah, when they come in, they have to fill out the sheet
Okay.
on the other side.
And they have it there. Okay.
Smiley faces.
Working from inpatient, I would say probably you've all heard that the numerical rating scale is what's used most often, and obviously that has some problems associated with it, but it's what we use at this point. And then some psych assessment tools that are used within the pain context. The Beck Depression Inventory assesses depressive symptoms. MMPI, the multiphasic, Minnesota Multiphasic Personality Inventory, a phenomenal measure of personality. It's really one of the most widely used clinical scales. The problem with it, it's very, very, very long. So I think it's 567 items. It takes like 2 hours. F reading level is pretty decent. So it's not really that practical to use certainly in an inpatient setting and even in an outpatient setting because it's so timely. But if you have the time, it's a great way to try to assess for various personality features. SCL-90 is a symptom checklist which gets at all different types of symptoms. It's really good to measure progress, so it's a good pre- and post measure. Multidimensional pain inventory really looks at how people have adjusted to the pain, and the coping strategies just assesses how they've coped. So these are all great to use, and especially if we're collecting research, it's great to use more of a structured inventory. One of the problems, before I move on, is that most of those are self-report. So, you know, pain is subjective, these measures are subjective, so it creates an issue, but it's pretty tough to get around that because we can't speak for another person's pain. There's also the facial, using the faces, and then just observing pain behaviors, which I think is another somewhat more objective way to assess pain, but we're kind of stuck with those methods. Then in terms of the structured clinical interview, which is also done much more frequently than those formal clinical measures, here's some of the basic, I'm just going to go through the basic points that you want to hit on when you're doing a structured clinical interview. And again, for palliative care, this would be the same. I would say major differences would be, aside from pain history, you also want to take an illness history. You want to take the history of kind of how they had been either brought to the hospital, or if you're seeing them outpatient, the history and the narrative of their illness. I usually like to start an interview off. You're trying to build rapport with the patient. You're trying to get them to be comfortable enough to be open with you, to give you as much information as possible. I usually start with the basics. You ask them your name, you introduce yourself, provide your name, and try to get at the key things. So their marital status, are they employed? If they are, what do they do? If not, what had they done in the past? Their educational level, that gives you just kind of the basic demographics. Then in terms of the pain history, depending on how much time you have, if you have, let's say, an hour for an interview, which I often have, I think you get a lot more if, rather than asking bulleted questions and very specific questions about their pain, if you first just ask them to tell you the story of their pain. Now, that's sometimes a dangerous road to go on, and it could take you kind of in a spiral, but you could always redirect the patient and say, you know, in the name of time, I'm going to switch over to asking you some specific questions. But it's interesting to just hear how they describe their pain. You could pick up a lot of personality pathology and personality traits when you hear somebody's narrative, if they're histrionic and they're telling you in this very dramatic way about their history, if they become tearful, and you could see immediately that they're struggling to cope with their pain as they're talking about it. So I always like to start by getting just the narrative of their history. And then these are the other key points if they don't go through it on their own. You want to know about onset. You want to know about how they rate their pain intensity-wise, what things make their pain worse, and what things make their pain better. It tells you a lot about how somebody is coping if they say, absolutely nothing makes my pain better, everything makes my pain worse, you know, and they could list a million things that make their pain worse, and they can't name one thing that makes it better. There's also patients who come in and can't tell you specifically where the pain is located. It hurts all over. diffuse kind of total body pain. So that gives you a lot of information about the person and also about what they're experiencing. And then treatment history, not just what treatments they've received, but how they did with those treatments. So if they tell you, I've been in pain psychotherapy, not enough to just get that information. You want to say, for how long? How did it work for you? Because if somebody had 2 pain psychotherapy sessions, I'd like to think that I could help people, but in 2 sessions, I don't know that I could do that much. So that's telling you they might not be compliant, or they might not be adhering to treatment. Same thing if they tell you, that they have tried a certain medication and it didn't work, and then you find out that it was an SSRI and they tried it only for a week. Tells you a lot about what they're going to do in terms of if you offer them a treatment, how they might handle that. Medical history, obviously important for any kind of clinical interview that you're doing. Now, psychosocial history. These are the key points. Obviously, sometimes it's difficult to touch on all of them, but I think the more you get, the more you can develop a really comprehensive treatment plan. So some of the key points for psychosocial history: family of origin, that's where they came from. Where'd you grow up? Usually I start by asking that, because sometimes it feels awkward to say, like, tell me about your parents or something like that. So where did you grow up? Tell me a little bit about your parents. Are they still married? Are they still living? How many siblings do you have? So family of origin information. I usually then ask something generally, like, tell me about the quality of your childhood, or what was your childhood like? And then that might allow you to lead into a question about trauma. I think it's really important to know a patient's trauma history. There's really high comorbidity rates between post-traumatic stress disorder and pain, and personality pathology. All 3 of those are really correlated pretty strongly. So it's important to touch upon trauma history. However, that's something you want to, be careful about, and just be sensitive how you're asking it. Trauma is something you should ask open-endedly about, because we don't want to put our own biases or impose that on somebody else. So a lot of people will ask about trauma by saying, were you ever sexually or physically abused? That's asking certain questions, but that's not covering the full range of trauma. I have had multiple situations where people say, yes, I've had trauma. They become tearful. They're talking about it. And it wasn't physical or sexual abuse, but it was something that they experienced as being very, very traumatic. So I think asking open-endedly throughout your life, have you ever experienced anything that you would consider to be traumatic? And then asking some follow-up questions. If you find that the patient is becoming very overwhelmed by this, very overwhelmed by talking about this, then I would take a break, take a moment to just say, why don't you take a breath, and then, casually move on, checking in with them towards the end of the interview if they're okay, and making sure that they feel safe leaving. You could always refer them to me if it's happening within this hospital, or a social worker or another mental health provider if they feel they need more time to process that or go through it. School functioning helps you a little bit determine kind of where they're at, reading level, where they're at cognitively. And if you're going to assign things like reading activities or things like that, some patients, that wouldn't be helpful to them, so it helps you, again, determine what you might put into your treatment plan. The nuclear family information is children, husband, their family at this moment. Some families, obviously, being culturally sensitive. Some families consider aunts and uncles or friends to be part of their nuclear family, so you want to ask about that. Substance abuse history, very important within the pain world. Psychiatric treatment history, and psychiatric symptom history. Okay, so the mental status exam, it's something that we've all probably had to do at some point or another. I'm going to go into it in a little bit of detail because my experience is that over time the mental status exam gets shorter and shorter and shorter, and sometimes we lose some really vital information. Also, sometimes just the language gets a little bit mixed up. So I'm going to go through some points. If anybody has any questions at any point, let me know. I like to think of mental status as starting from the outside and going in. So you're starting with the most overt things, and then thinking more in-depthly internally what's happening with the patient. So overtly, first big thing is general appearance and behavior. Is the patient unkempt? I'll go through, this is just all of the things, but I'll start now. So level of grooming, level of hygiene, what they're wearing, what their attitude is. Are they very easy to engage? Are they very guarded? Are they reluctant to engage or resistant to engage? Their psychomotor activity. Is their leg bouncing like crazy as you're talking to them? Or are they moving very slowly? And the degree of eye contact. So is this somebody who's completely avoiding eye contact or staring in a kind of inappropriate way? Speech, we're looking at spontaneity. So is this somebody who only answers when asked a question but doesn't produce any spontaneous speech? You would get that again when you ask open-ended questions. So this is the person that when you say, tell me about your pain history, they say something like, I don't know, and they need you to ask the specifics. So that's, poverty of speech or lack of spontaneous speech. Their rate, is it rapid? Is it pressured? Sometimes people confuse rapid and pressured. They feel very different. I often say that you know when somebody evidences pressured speech because you can't get a word in. You literally, it's almost impossible to get a word in. If anybody has worked with a patient who's manic, often they have pressured speech, and you feel it. An intensity kind of comes into the room, and it's very difficult to interview them. That's very different than somebody who's just speaking very fast, but open to, if you say, hold on, let me just take a second. Somebody with pressured speech, it's really impossible to do that. So important to distinguish those two. Volume, normal, soft, or loud. Perseveration, that's important because it might give you some window into cognitive impairment. So I know Nina and I interviewed a patient the other day who we would ask a question, and then multiple times after we asked that question, they would just repeat the last two words of what we said. So they were perseverating. Echolalia, just repeating things. Neologisms and clanging, that's really more in a psychiatric setting that you'll see that. I don't think you'll see that too much here. And that's also for mostly psychotic patients. So thought process is how patients are logically making connections between things. So if they are answering questions pretty coherently and going from one point clearly to the next, we would say that they're logical and goal-directed. Do people know the difference between circumstantial and tangential? Because those are different and they also get mixed up. Does anybody know the difference between circumstantial and tangential? What'd you say?
Isn't tangential just random thoughts that are unrelated to one another?
Yeah, so I always remember it because if you could think of circumstantial, circle, kind of the word is in there. Circumstantial is they kind of get to the point, but they get to it in a roundabout way. But the key is that eventually they get to the point. So they might be taking you on these like massive circles outward, but they eventually get to the main point. Tangential is they go out there and they never come back. So they are never getting to the point. And like you said, it's kind of random thoughts and they're going in their own direction.
Let's say circumferential, is that the same?
Circumferential? No, I think it's just circumstantial. I haven't heard circumferential. Is that something that you've heard or heard people say?
I thought it was.
Okay. No, I think it's circumstantial. But I might be wrong. Flight of ideas is usually just a rapid kind of firing of thoughts. Again, that might happen with people who are manic. Might also happen in various psychotic disorders. Can happen also for people who are extremely, extremely anxious. Loose associations is it's really tough to make any kind of logical connection between what their thoughts are. And blocking is when somebody kind of randomly seems to be unable to produce thoughts. Again, seen in a lot of psychiatric settings. Thought content is kind of what exactly what it says. So, you know, what is the content behind their thoughts? And there are delusions that people can have. Those are the various types of delusions. There are preoccupations, which are thoughts specific to something, but they're not considered to be unwanted. So this is preoccupations and obsessions often get mixed up. We could think of them as preoccupations are not unwanted. I don't know that they're necessarily wanted, but they're not recognized as being unwanted thoughts, whereas obsessions are recognized by the patient as being unwanted. So many of the patients with chronic pain have, or the somaticizers have preoccupations, somatic preoccupations, as opposed to obsessions. Ideas of reference are also seen in psychotic disorders. That's when patients might hear something on the radio. They might be listening to the radio or see something on TV, and they think that the radio person or the TV is speaking directly to them. Suicidal ideation falls under thought content, and I'll get into that a bit more. And aggressive or homicidal ideation falls in there. Perception, hallucinations, auditory or visual hallucinations, rarely do they occur simultaneously, so it should send up a red flag if people are saying that they're experiencing both. You want to really assess for secondary gain. Illusions are just misinterpretations of reality, and then derealization, depersonalizations are experiences that people describe, almost dissociative experiences, where they experience themselves, they feel like they're not themselves. That's depersonalization. Or they feel like they're not real. Those are various types of perceptual disturbances. Then mood and affect is another one of these things that get confused sometimes, and I think it's really important to make sure that you understand the difference and that you assess each of them. So mood is the internal emotional tone of the patient. So it has to be, it's entirely subjective, and it has to be provided to you by the patient. So if you don't ask this, you can't really speak of it. So you can't just say the patient is depressed without actually saying to the patient, how are you feeling today, or what's your mood today? Because once it's your observation, then that becomes affect. That's no longer mood. So mood is the internal emotional tone of the patient, and usually when I'm documenting mood, I actually put it in the in quotations, because it should be in the patient's own words. They might say something like okay, and you could ask them to elaborate, but document it exactly how they say it. As part of when you're assessing how they feel today, they might touch on various specific things, and those really fall under more of the neurovegetative symptoms. So they say, well, I'm really exhausted, I haven't been sleeping, so then you could put it under there. Affect is, like I was saying, it's the external range of expression. So it's your observation of the patient's expression and emotions. And when we're talking about affect, we like to talk about it on multiple dimensions. So we talk about it, the quality. So are they euthymic, which is kind of even? I like to consider that in between. If you have a range of euphoric being on the end, where people are almost manic, excessively happy, excessively high. On the other end is dysthymic or depressed. Euthymic kind of falls in the middle. So that's the quality. The range, are they all over the place and have this really broad range of affect, or is it kind of blunted or flattened? The stability or the reactivity, are they kind of stable and euthymic throughout the interview, or are they really labile? That tells you a lot about the person. And then appropriateness. People talk about appropriateness in different ways. Sometimes I say affect appropriate to mood. So if they seem to me depressed and they report feeling depressed, appropriate to mood. If they are talking about specific things, and as they talk about certain things, they react emotionally, but in an appropriate way, then you often say appropriate to content. So speak about all those things in terms of affect. Cognition, these are the various aspects of cognition, and sometimes what happens when people say they did a mental status, they are just referring to cognition. So it's important to know the mini mental status just assesses cognition, but the mental status exam has to cover all of these other areas that I've been talking about. So mini mental status is cognition. Mental status is all of these things. Cognition, these are the different things you want to look at. Level of consciousness, so are they alert? Are they sedated? Orientation, person, place, and time. So usually we talk about it oriented times 3. Attention and concentration. Have you guys done the spell world backwards? Sometimes they seem ridiculous to do, but important to just assess these things. Short-term memory, 3 objects. You say the 3 objects, have them repeat them back to you right away, and then wait about 5 minutes and ask them to recall them. Fund of knowledge, you might ask who's the president now, who was the last president. You might ask them about if they could list 5 cities. Calculation, serial 7, so you start at 100 and you say subtract 7 and keep going until I tell you, so they go 93 and then they just keep going. And then abstraction, my go-to one, because it's easiest for me to remember, but you could use whatever proverb you want to determine if they're, what their abstraction skills are like. I usually say people in glass houses shouldn't throw stones and ask them to just explain that to me. Interesting to see that some people really struggle with that. So, insight is how people understand their current problems, their current illness. It might be in a palliative care setting, their illness potentially and prognosis if they've been given that information. In a pain setting, their pain condition and how it affects them. And usually we when we're documenting insight, we might say good insight, adequate insight, impaired insight, or unable to determine if you haven't really been able to ask them about it. And judgment is just their ability to make sound judgments. And again, we usually talk about adequate judgment, inadequate judgment. So suicidal ideation. This is something that, again, in terms of pain context, we know there's high comorbidities with depression. We also know there's high comorbidities with suicidal ideation. So it's really something that we have to get good at assessing. And it's tough to assess suicidal ideation for a lot of reasons. I plan to do a full lecture on suicidal ideation, so I won't go into all the details, and I have a lot more statistics on it. But my experience is when a high-functioning patient walks in the room, bless you, high-functioning patient walks in the room, or if we have a high-functioning patient in the hospital that we walk into their room, for some reason I find that people, not for some reason, I think it's understandable, people get squeamish around asking questions about suicidality. I think people are worried about offending people. I think people assume if someone's high enough functioning and they've seen lots of visitors walking in and out of the room, they assume, oh, this person must not be suicidal. Or if the person has been a, so to speak, easy patient, a not difficult patient, their smile when you walk in. We don't ask that question. But in reality, it should just be part of our regular assessment, regardless of how the patient presents to us. I have found people to be suicidal who other clinicians had interviewed multiple times and missed it because they just didn't ask the question. So you really have to ask this. And what I find is if you could find your own language that you feel comfortable with and approach it in a certain way, it doesn't feel as uncomfortable to ask about it. So here's some things that I've found to be helpful in terms of assessing for suicidal ideation. So sometimes what happens if you are squeamish, somebody will say something like, "You're not suicidal, are you?" That's not really asking a question. That's leading a patient, and I think, in my opinion, the patient has no choice but to say, "Absolutely not," or, "No, I'm not." So what I usually suggest to people is instead of immediately asking about, "Are you suicidal?" I usually say, start with something just about, how do you feel about living? So you might say, how is it for you to live on a daily basis with this pain? If they say it's awful, or, it's really, really difficult, that they usually give you the language to ask the follow-up question. So the patient who says, it's so hard to do this, but I try to make it through, I will usually say something like, does it ever feel so hard to live with this pain that you think about hurting yourself or you think about ending your life? So it's not, are you suicidal, a very kind of technical question, but you're having a conversation with them about these thoughts. It elicits a lot more information. And people may have not really actually, they might not know what you mean when you say, are they suicidal? They might think, oh, I never took a rope and tried to hang myself. They don't really know what you're trying to get at. So you ask some follow-up questions now about more how they feel about death. If the patient says, sometimes I do, then again, you need to follow up with a number of questions, not only to make sure that they're safe, but also to document, why you feel that they're safe or why you feel that they're not safe. So if they say that they have had thoughts of ending their life, you ask follow-up questions about how often do you think about that? What is it like when you feel that way? And then if you have thought about it, do you think about ways that you do it? So you're assessing, do they have a plan? Do they have intent? How often is this happening? And then one of the questions that I also think is important to ask that gets missed a lot is, if you have had these thoughts, and you have had these plans, what stops you from doing it? Because you want to know, what are their protective factors? I had a patient the other day who had very frequent suicidal thoughts, but then in terms of his protective factors said he's Catholic, it's against his religion, and he would absolutely never follow through on it. So his level of risk is significantly lower than I first thought it was in just hearing him speak about it, because his protective factor is not something that's unstable. His religion, as he said it, is something that will constantly be there as a protective factor for him. Some people say, will have contingent suicidal thoughts. So they'll say, we had a patient recently who said, whose wife was sick and dying and said, when my wife dies, I'm going to kill myself. So in that moment, he's not a risk to himself, but we can't predict when his wife is going to actually die. And that contingent suicidality is cause for concern because his protective factor is really unstable. His protective factor is his wife, and she's going to die. So we really want to get at all of these questions. And one of the highest sources of risk for suicidality is previous attempts. So you want to also say, were there times in the past that you actually attempted to kill yourself, and how had you done that? So if it's a patient who comes outpatient to our pain clinic and has attempted to kill themselves by overdosing on a prescription drug, that's going to make us feel a little bit different and be a little bit more cautious in how we're prescribing medication to them. Not that we won't prescribe medication to them, but what safety measures are we going to put in place so that this doesn't happen? Any questions with that, or any experiences where you wanted to do this but felt uncomfortable doing it, or tried to do that but kind of came up to a barrier either because the patient was guarded or couldn't find the language to ask these questions? Do people, when I said that I think that there's some people tend to become a little squeamish around these questions, have people experienced that where you feel a little bit like, I don't want to ask this question, of course they're not suicidal? Okay, that's good.
I love it.
You love it, exactly. The other question that I find that people get squeamish around is trauma, so which I spoke about before. So they're tough questions to ask. They're also, you can get to a dark place. You could see the patient's vulnerabilities, and that sometimes makes us uncomfortable when a patient is so vulnerable in the room. But we have to kind of break through that and work with that. Now, this speaks to the role that I have here in evaluating appropriateness of medical intervention, the stims, pumps. I'm hoping maybe, it's possible that in the future even other types of procedures might warrant evaluation, psychological evaluation before they occur. There's been all sorts of research that talk about risk factors for people who are going to undergo a procedure that have made many insurance companies actually mandate psychological evaluations before these procedures, and I think eventually all insurance companies will mandate them. So, and most pain clinics are just making it part of their practice, which I think is pretty smart. A good example is where I had worked before. A patient had undergone a spinal cord stimulator procedure, had a spinal cord stimulator placed. It was a young adult patient, who hadn't been evaluated prior to receiving that and hadn't had a full kind of background check, so to speak, hadn't really had any kind of intake. And the patient had been very impulsive prior to receiving this, and had also the week before attempted to commit suicide. And nobody was aware of this when they put this spinal cord stimulator in, and the day after she had it put in, she had to have it taken out. She had a lot of paranoid thoughts about it, and was scratching her back. And so this is, one of those extreme situations that we really hope doesn't happen, but something that could have been prevented if the proper measures had been taken prior to that happening. So questions that I ask in my interview, aside from getting the full background and doing the full assessment like we had been talking about, I also ask specific questions related to the procedure. So do they understand the mechanism? Are they capable of understanding the mechanism? If it's going to require maintenance by them and they aren't capable of, working a television remote, that's cause for concern. Then we really need to do some psychoeducation before this person has this device implanted. For a pump, are they compliant? Are they going to be coming to the clinic to have it refilled? Or are we going to be worried that this patient is going to go into withdrawal because they're not able to follow up with their medical team? What do they imagine their emotional reaction is going to be to the surgery? Obviously, it's hard for people to anticipate, but just to hear them talk about the surgery, you really get a feel for, is this somebody who's going to freak out after they leave the OR? Or after the surgery, are they going to be extremely anxious and unable to appreciate the possible benefits of the surgery? Expectations. We want to make sure they're appropriate. If somebody that I'm interviewing says that they are hoping for a complete recovery and no pain after the surgery, I have to do a lot of work to adjust those expectations, because for sure they'll assume the surgery was a failure. Plans for pain management, so assuming that they're not going to have a miraculous recovery and the pain's going to go away, what do they plan to do to continue to treat the pain? What are their hopes? If the procedure is somewhat helpful, is their goal to eventually restore some functionality in their life? Is it that they have specific things that they want to do with their families or their friends? And then the dreaded question that patients don't love to hear, but you have to ask is, what do they anticipate their reaction would be if it's not even remotely effective, if it hasn't changed their situation at all? These are just some basics, so those were kind of the specifics, the nitty-gritty of the interview, but I think these are some basics to talk about in terms of how we approach our patients, things that we don't think about very often but really convey a lot. And the first thing that I will say, there was a quote that I wanted to bring in, but it just spoke to how kind of in the pain world we're completely dependent on our patients because of the subjective nature of pain. So the way we establish a relationship with our patient is going to make a huge difference for how their pain treatment goes. So first point is establishing rapport. You walk into that room, if they don't feel comfortable with you, they're going to remain guarded throughout the interview and give you very, very little information. That doesn't help you, that doesn't help the patient, that does nothing. So how are you going to establish rapport? I always say, be human. They're humans, you're human. Remember to be human in that room as opposed to walking in as just a doctor or as the expert. Be a human in that room with them. So making eye contact is important. What your body language is, what your facial expressions are important. Do you shake the patient's hand when you walk into the room? Do you sit down when you walk into, if it's an inpatient room, are you going to stand over their bed or are you going to sit down? Those all convey different things, and I'm not here to say one is right and one is wrong, because I think it's what feels right for you, and I think it depends also on the patient. Sometimes it depends on the environment. Sometimes in the ICU you can't really sit down with the patient if the family member is there and they're sitting. But just to think about that and what you're conveying. I think sometimes if you're in a hurry, you might be standing over the patient's bed because that's what you had done with the previous patient. You're already thinking about the next patient you have to go. That conveys a message to that patient, and it might be, oh, this doctor is rushed, so they're not really paying attention to me, or they're not really hearing me. And you might be hearing them, but that patient doesn't feel that way. So it's really important to just check in with yourself and think about, if I were in this bed, or if I were coming into this clinic, how would I want to be greeted? What would feel okay to me, and what would help me to open up to this clinician? You want to remain as objective as possible throughout the interview. Pain patients are complicated, and they, because there's so much comorbidity with psychopathology, with personality pathology, they elicit reactions in other people. They elicit reactions in their families and their friends, and they elicit reactions in us. We're not perfect at being objective. So I think, again, not only body language-wise, but also emotionally, it's important to check in with yourself. If you're finding that there's like steam building up within you because this patient is really pressing your buttons, maybe you need to step outside for a minute. Take a minute to decompress so that you could come back and be objective with that patient. I know kind of built into psychology, we have a lot of peer supervision, there's a lot of process groups, but that doesn't happen always in the medical setting. And I think sometimes informally, just touching base with each other is important to make sure that you don't kind of get burnt out in this field that demands a lot of you guys. I also think it's important to try to remain as empathic as possible. And I think if you find that there's barriers to you feeling empathic, so if you start feeling like, oh God, this person's a pain in the butt, or this person is lying, or this person's faking, it's important to remove yourself for a moment and check in. You might be picking up on something that's going to be helpful for your treatment, but you also might be having some kind of countertransferential reaction that's going to get in the way of your treatment of this patient. So you have to check in with yourself, and also use your peers to help you check in with yourself. Sometimes we need somebody else to help us become objective again. Providing feedback is something that I think is helpful. Again, I'm not here to say if it's the right way or the wrong way to engage a patient, but I find if you're going to be asking and drilling a patient with tons of questions, if you have an observation, if you have if you come to an insight about this patient, or you have a thought that might be helpful to them, I think it's good to share it. So, you know, I have been seeing a bunch of new patients here, and sometimes in the middle of the interview, if it strikes me that they are using humor, they keep making jokes about their pain, I will sometimes take a step back and say, I just want to comment and let you know I see that you use humor a lot. Is that something that helps you cope with your pain? Maybe that's one of your coping strategies. So they see that I'm fully engaged, and this isn't just about what can you tell me, but it's about a collaboration, which eventually all pain treatments have to be a collaboration between the patient and the clinician. So why not set that whole concept in motion from the very beginning? Are we out of time? Is that why they're all here? Are we okay with a couple more minutes? Okay. I skipped ahead. In terms of, I had given you guys a couple suggestions in terms of asking questions open-endedly, you know, the pain narrative, asking about trauma open-endedly, even sometimes asking about suicidality open-endedly. Obviously, for the sake of time, you sometimes have to get very specific and direct questions and really direct the flow of the interview, and I think that that's fine. But at the same time, I think it's important to be flexible in your interview. If a patient in the middle of your interview becomes upset, it's really important to acknowledge what you're seeing. So I see that something's making you upset. You may have had a whole series of other questions that you wanted to ask, but if you don't acknowledge the patient's emotions in that moment, they're going to assume either that you can't handle them, and they might not be as open with you moving forward, or they might just shut down. So it's important to be flexible in your approach to a patient and take a moment and acknowledge what they're going through, try to explore a little bit what they're going through, and then once you feel that things are stable again, you could say, okay, let me ask a few questions and get back on track to your interview. And with that, you know, I think this has been part of the whole thing. Just conveying your openness. As soon as a patient feels that you have an agenda with them, other than the basic agenda of trying to find out as much information, if they feel that you're guarded, if they feel that you're uncomfortable in a certain way, most people shut down. I think that's part of human nature. So the more open you are, the more open patients will be. Oh, okay. I think that was my time signal. Okay, so I put a few case examples. I don't know if we're going to post these or not, but interesting to look through just because on paper these two patients looked somewhat similar in terms of pain profiles, and their mental status exam is what really differentiated them. So their histories were similar, their actual medical problems were similar, their pain symptoms were similar, but how they behaved in the interview and the various observations that I made mental status-wise really changed our treatment plans dramatically. So it was a nice example to see kind of how a full integrated intake can really help you. That was it. Thank you.